So great talk. So really important to put all our work together in an international perspective. But an important point, I think, at the end was don't get too distracted about international performance, because we can see that we've still got a lot of work to do at home, and that we need to focus where we make most difference. And the majority of us make most difference when we see patients every day and try and support them in their self-management. So our roles as clinicians is really, really important back at base. Really important message. Okay, Rob, it's your turn. Yes, can I introduce you to the audience? Come on forward. So Rob actually works in Cardiff, and he is a senior lecturer and is a statistician. But we know we're jealous of statisticians, aren't we? Because we've got this perception that if you're a statistician, you can get to the data immediately and you can do something fancy with it immediately and see a lovely picture that informs everyone. But Rob informs me that being a statistician isn't really like that. It's still hard work.
Yeah. Well,
so I'll leave you to tell everybody about the challenges. Yeah. Great. Thank you very much.
Okay, yes, so just as suggested there, I'm a statistician, but I spend most of my time actually trying to get hold of data and link data rather than actually being able to run all the statistical models we want to. But I'm going to talk about some of the research we've done, but I'll also mention some of that foundational work about getting data, some of the engagement we've done with young people. I'll talk about the research, some of the outcomes, and then I'll mention some of the policy work and future research. So just in terms of the discussion today, so we're thinking about how does diabetes affect education, and perhaps we can also think about how does your educational experiences affect diabetes management. The co-authors there are all involved with the actual research project itself, but there's many more people who've been involved primarily in collecting the data, but also engagement, including the schools network and so on. Right. Okay, so this first example here, actually. No? Ah, brilliant. Okay. Yes, so this is a simple first question, thinking about the effect of health on educational outcomes. So a diabetes diagnosis switches on, switches off, or it doesn't switch off, sorry. It switches on, and then you change. Oh, sorry, I'm not talking about this real. A simple diagnosis of diabetes is quite different from some of the other measures we might use. So I'm using this as a simple example of something that might have an effect on your exam scores. The things that might influence this relationship are things like gender and also other characteristics about your perhaps your family, your household, your school, your clinic, and so on. But effectively, we're trying to model a simple relationship between a characteristic, whether you have diabetes or not, versus your exam scores. Now, I've mentioned gender, so gender might have an effect on whether you have a diagnosis of diabetes or not. If it's more prevalent in boys, for example. Education, girls and boys have different attainment across the board. Girls generally having higher attainment, with boys perhaps over-attaining in some subjects. Then also there might be a difference then, that gender effect on how well you cope with your diabetes in schools. So then that's more the focus of what we're looking at. But there are those three independent factors. I mentioned about other families, clinics, and schools. So as a statistician, we think about that as the clustering. We might have multiple children within a family, multiple children within a household, within a clinic, and so on. And some of Justin's graphs try and collate information at the clinic level. And so there can be a clinic effect that we talk about, and that's to do with the average level of HbA1c, or in my study, it could be the average level of educational attainment at that school, at that clinic. So there's those cluster effects. And of course, there's the characteristics of the clusters as well. So small or large clinics, small or large schools, small or large households, and so on. Right. I've mentioned here about the focus on diabetes as well. And what I'm thinking about here is why do I ask, or why am I justified in asking for lots of funding to work on diabetes when there's lots of other health conditions? And although to this audience, I guess you're quite sympathetic, it is something I have to talk about quite a bit. And my sort of experience in some of the meetings I'm at is that we really are ahead of the curve when compared with other conditions. So firstly, because it's a common condition, that we've then got the larger numbers, we've got a bit more heft when we make an argument because there are a significant number of people that are affected. We've got accurate identification of cases, and then we're comparing this to other researchers who know working on asthma, where perhaps it's harder to pin down who exactly has asthma versus not in the data, at least. And then, of course, the well-established audit records. And so it's not just about identifying children with diabetes, we've also got all the health measures, we've got the other measures like BMI, we've got the care processes and so on. So having all that extra information about treatment regimes and so on really helps us say more and perhaps helps support all the other health conditions that are operating in schools and requiring support in schools and requiring teachers to be trained, requiring all the facilities and so on. Right. So that's a first example. I'm just going to show a second example here to talk about another sort of statistical problem that we have to deal with in this research. So the example here is blood glucose levels and the effect on school absence. So here we have the same kinds of things, gender and so on might affect both of these things in the relationship. We also think about the other factors that might affect these individual characteristics, the age of diagnosis, your age at the time and so on, family characteristics, household, school and clinic. But then there's a third element here, which is that sometimes then your education might be influencing your health. And statistically, this is challenging because if two things are operating in different directions, it's hard to quantify what the overall effect is. And luckily, because of the audit, having repeated measures over time, that gives us a way of sort of teasing out some of that causality of one direction over another. Okay. Right, so following Reinhardt's map approach, I have tried to map some of the research on the links between education and diabetes for these three questions here. And immediately you can see that in terms of the evidence that's based on large administrative data sets where we've got high stakes educational attainment measures measured at a national scale, we really have relatively sparse evidence in terms of worldwide coverage. There's further studies from the US that are more regional but aren't included on here because they don't quite meet the criteria. And in fact, we did a systematic review of the evidence on educational attainment by type 1 diabetes status and type 1 diabetes health. And only 2 studies met all the quality criteria, and they were both from Sweden. So I've been a bit more relaxed about the studies I've included here, and we've included studies from all these countries on the left. And you'll see they're mostly kind of Scandinavian countries or countries with good data. Some gaps include Canada, Germany and other places, but still we're not seeing a wonderful coverage in terms of the evidence. So in terms of this first question here, type 1 diabetes status and school absence, is fairly conclusive evidence across most of those countries that type 1 diabetes does increase school absence. There's not a consistent figure or proportion, but there is an agreement that there is that negative effect. The second question, effect of type 1 diabetes status on school achievement. So this is more mixed. So the 3 studies from Sweden all conclusively agree that there's a negative effect of type 1 diabetes on educational attainment. However, studies from other countries argue, particularly from Denmark and Scotland, that overall there's not a negative effect of type 1 diabetes. And then other countries like New Zealand have shown both effects. So they've got some studies which show a negative effect and some which show no effect, and the same for Denmark as well. So the evidence is mixed on there, and it's probably not that there's one universal truth, so there probably is differences. I mean, we saw in Justin's graph or Reinhardt's graph the distribution of different HbA1cs across countries. So of course we might not expect a common effect across all nations. Then the third question is concerned with the type 1 diabetes health. So this might be counts of DKA, it might be other hospital admissions, or it could be just HbA1c levels. And again, there's a general consensus that there is some negative effects associated with those on school achievement, as you might expect. But again, thinking about the distribution of HbA1cs, it might mean different things in different countries. Okay, so in terms of the data for our study, we were thinking about connecting these data sets. I've mapped age across the top here with some icons, but the idea is we've got schools data, college data, university data, and then graduate destinations for those who have attended higher education, including measures like income and so on. And then we've matched those with the National Paediatric Diabetes Audit, which is provided by RCPCH, controlled by HQIP, and then the National Diabetes Audit as well to follow people up into higher education and beyond. What should I say about this? This has been a big challenge. All of these data sets are controlled by different people, and in fact, for some of them, we've got different controllers in Wales and England, and so it has taken a lot of time to try and pull these together. I'll mention a bit more about those challenges on this slide here, yes. So these are the main challenges we've had, but I'm just going to focus on a few. So the second one here the third, where has it gone? The common law duty of confidentiality, this one here. So this is protection that when a young person enters a diabetes clinic and gives information about their health, that's protected, their confidentiality is protected, the data is given for that purpose and that purpose only and shouldn't be shared beyond that clinical team. But they can make an exception to that, and we can have a raising of the common law duty of confidentiality to share those identifiers to then link that data. So we use the name, date of birth, postcode and so on for that child to then link to the name, date of birth and postcode of their education data. But it's quite a time-consuming process to get that approval. The second point I'd like to highlight is all of these data providers, then the data processors who handle the identifiers and make the linkage, and then the data repositories. I'm not going to go through what they all are, but they all have to work together, and they're not designed to work together. So a data provider is designed that I apply to Royal College of Paediatric Child Health for some data, and they send it to me to do some research in an anonymised format. Organisations aren't used to having to work together and make agreements, and there's so many different contracts, and even just organising the contract structure is very time-consuming. I've mentioned at the bottom of timescales. I mean, to give you a sense of this, we started to think about this in 2014, this research. We got our first funding in 2016, and we've been well funded to do lots of the data linkage and also lots of engagement and so on in that time. But and we're still waiting for some parts of the data. So it really is a very long process to get hold of data and work on it. And as part of those approvals, I mentioned about the common law duty of confidentiality, that what part of the constraints for getting that data is you have to do lots of engagement with young people and understand what they think about that processing of the data. So we have a co-production group for the research. We have had some challenges in having coordinators keep that ongoing, but I think we've now secured some more funding for the next 2 years. We had a steadfast project where we did an engagement with 80 young people, 18 different focus groups where we talked about what was happening with their data and what kind of research questions they'd be interested in that space of education and diabetes. And one thing to mention here is we tried to get these underrepresented groups into those engagement sessions, and it was a real challenge actually. We worked with lots of different people, particularly Diabetes UK, but other organisations as well, to try and reach those groups, and still we didn't make our target of 50% of participants from underrepresented groups. It was really challenging. Okay, so the data itself. So this is the data for Wales. The data for England has been coming in slowly over the past year, but we're not ready to present those results yet. But this is just to highlight, I guess this is the complete cohort here, 18 educational cohorts. And to give you a sense of the numbers, we've got reduced cohorts because not all of those children who are in schools will have done their GCSEs yet. And equally, not so many cohorts will have gone to university. So we've got 6 cohorts that have gone all the way through to university, 8 cohorts with data up to their GCSEs, and then 18 cohorts where we have some educational data, so we've got their absence data for each year they've been in school. Might just flag 2 things here. So firstly, the proportion on special educational needs. Now, I assumed children with diabetes would get a lot more support in schools, but actually these figures are fairly comparable with what we'd find nationally for children without diabetes. And I was also thinking, particularly in Wales, where we've got this additional learning needs and we're trying to be more comprehensive in how we support children, I thought we'd have higher rates there, but they're not. Okay. Right, so on to the results. I'm going to show you several slides like this, and they look a bit complicated, but they're not really. They're just split into 2 parts. The left-hand side is a comparison of children with diabetes versus their peers without diabetes, and the second half has 5 estimates, and that's for the 5 quintiles of HbA1c or average HbA1c, and again compared with children without diabetes. This first graph is talking about school absence by type 1 diabetes status. So our 0 here is the number, is the average for children without type 1 diabetes, and then we're looking at the excess days over and above that. So our estimate for children with type 1 diabetes is 9 excess, not days, sessions, 9 excess sessions of school absence per year, year on year. And when we break that down by HbA1c quintiles, so the lowest HbA1c quintile still has 7 excess days, excess sessions of absence per year, and the highest HbA1c group has just over 15 excess sessions of type 1 diabetes, excess absence per year. So we're really seeing a lot more time off than we'd expect. Interestingly, it's not just authorised absences as well. About 10% of those for the most optimal group and 20% for the least optimal group are unauthorised absences. So again, we don't know why those are higher for children with diabetes, but there's clearly an absence story there. So our second chart then takes those same groupings and thinks about the educational attainment. So we know those children have had those excess days off, so we might expect them a priori to have lower attainment, but actually this graph here shows a 0 for the average attainment for all children without diabetes, and then looks at a deviation from that. So we see there's almost no deviation for children with type 1 diabetes from the average for their peers without diabetes. So, I mean, that's quite surprising for me, given the excess days off. And to me, it shows from our work with our co-production group and others that I think they seem to be working harder, perhaps, to make up for that time. When we break that down by the HbA1c quintiles, we unsurprisingly see that those with the most optimal HbA1c are 3 standard deviations above the average for those without diabetes and 4 standard deviations below for the least optimal group. So in terms of grades, then, if we imagine there's the average for children with and without diabetes is 4 Cs and 4 Ds at GCSE. And then those with the most optimal HbA1c are 4 grades above that average. So the 8 Cs, 4 Cs, 4 Ds, it could be a different combination, but that's just to give you a sense of what it is. Whereas those with the least optimal HbA1c are 5 grades below. So, and maybe to give a sense of what a grade means. So each grade at GCSE is correlated usually with about £23,000 worth of income over your life course. So these are significant differences once you add them up. So that, just to recap, so 1 grade means over your life you'll earn £23,000 more for each grade higher, on average. So this attainment effect we're seeing, then we try and do some sensitivity analysis to try and work out what it might be that's causing this. So this graph now adjusts, we adjust for lots of other things in the graph, but now it adjusts for school absence as well and says, well, what if they had the same level of attendance as children without diabetes? And then we see that children with type 1 diabetes are overperforming in this group, and equally all of these shift slightly as well upwards to account for the fact that they're having more time off. So what this is saying is if those children didn't have that time off, they'd actually be overperforming, or the other way around, they're just working harder in the time they've got. Yes, okay. A second sensitive analysis is to try and think about HbA1c. Now we know, and in our data we see that HbA1c is associated with socioeconomic status. And so in this one here, we take that trajectory, or that gradient, sorry, in HbA1c and try and see if that is reduced once we add in the socioeconomic status. So in this graph here, we compare HbA1c quintiles for people without adjusting for differences in socioeconomic status. And then in this right graph, we add in controls for socioeconomic status. So we add in whether the children has free school meals or not, and then their local area deprivation. And what we see actually is it doesn't really attenuate a great deal. At the extremes, it attenuates somewhat towards 0, but socioeconomic status is not the whole story in this, or at least another way you might think about it is that compared to studies like the Denmark study where they had really good measures of household deprivation, we haven't got good enough measures of socioeconomic status to really account for this. I think that might be more of it rather than it's not an SES story. Okay. Another way of thinking about the socioeconomic status and maybe other factors that affect child attainment is to look at prior attainment. So in this one here, we repeat that same layout, but we think about our outcome almost becomes what's the progress between Key Stage 2, age 11, and Key Stage 4, age 16. And we only include here the subset of children that were diagnosed between age 11 and 16. And so what we're trying to say is here, all the factors that might affect your prior attainment, including your parents' socioeconomic status, your parents' motivation, the children's innate ability, all these things hopefully are netted out slightly by including this prior attainment. And then we do start to see an indication there might be some negative effect of type 1 diabetes overall. And in fact, we see that whole gradient being shifted downwards. So there is a story here, but unfortunately with this, the data we've got, it's a relatively small data set, so we're not able to cut this up to try and investigate this further. And we hope with the English data, we might be able to do some more of that. Okay, this is the last of these graph slides. And this is just thinking about, well, what if rather than using the HbA1c sequentials, we think about the age of diagnosis. And the logic here is perhaps exposure to diabetes increases, might have more of an effect. So if you're diagnosed at age 6, you've got 10 years of exposure at age 16 when you do your GCSEs versus someone who's diagnosed later. And comparing all of these different time points when you may be diagnosed, we effectively see no difference in attainment compared with the children without diabetes. So we're not seeing a gradient there. Okay, I'm just going to speak for a few minutes about the policy. So I don't want to go into detail on these, but effectively there are policies in place to support children with health conditions in their education. No child should be disadvantaged in theory, and there's guidance that goes along with this as well. And so we've tried to provide evidence towards some of these, particularly in Wales, because that was where we had the data done first. And we've given evidence to government, both in England and Wales, using our research based on the NPDA and on Swedish data as well for another study. And just a few things to highlight here. So one of the things I was most proud of was this persistent absence one. So in this study here, or in this government report, they were trying to think about persistent absence or absence being a problem for children from disadvantaged backgrounds or those kinds of behavioural difficulties and so on. And they hadn't really thought about health at all. So I think our input there was to try and make them think about health. And now there's a whole section included on physical health and mental health in that government report. I should thank Diabetes UK as well for their support in doing this policy work. And then just a short note on some ongoing and future work. So the first point here is about progression or extension of the work we've done already. So the first one is this homes, households, families, and there we're trying to think about, well, what about the area or the unit in which the child lives? And we're going to identify households in 3 ways. We've got the GP's address of everyone who lives at that address. We've got census data, which we hope to link to the NPDA, and we've got the mother-child link. So we've got children from a common mother identified as siblings. So the hope is to link those together and have a better measure of what's going on in the household, to perhaps compare siblings or have richer measures of household deprivation or other household characteristics. School exclusions, it's challenging because only a small number of children get excluded, but we think that might be worth looking at. So we've got a clinician from Bristol called Alicia Bernard who's going to help us look at that. Special educational needs support, and that's something we're looking at the moment, particularly for Wales, where there might be more of an overlap with the for support for children with diabetes. Ethnicity and mental health are the important things we'd like to look at, but they're in brackets because I think they require more data. Okay, so that's the research infrastructure. So one of the things we've been funded for is not just to do research, but also to help with the data. And we've been working very hard to try and link the data from England and Wales, and we're working with other colleagues to connect data from across the UK. And as part of that, we've got resources to help support people to access that data and to use that data. So hopefully towards the end of this year, there should be a call for some research funding for other people to use this data. So there are things in education and diabetes that you're interested in, please let me know and we can support you to help put applications forward for that. And then the third part is international. So I do have an aspiration to capture some of those data we saw from across the world and try and make a more aggregated analysis for education and diabetes. But that's an early work at the moment. We do have a workshop in October to discuss how we might do that. Yeah, that's everything from me. Thank you.
So enormous amounts of work, really, which is a great insight for us. A personal feeling about education is that we aren't at a stage where a mum or dad can take their young child and hand them on to the school in the morning and feel that they will have as good care in the school as the parent would give them at home. And that has to be our aspiration for the majority. In some respects, the school has to be a locum parentis for some of our poorly managed young people that are at home who nobody cares about their diabetes. But in the Swedish view about this, that I know from colleagues, is that if we get overnight right with automation, and we get school right with interest, support and automation, the responsibility for the parents, if it's really hard for them to manage the child, will be somewhat negated by good care overnight and in school. And I think that could help us hugely to try and accelerate our median A1C reduction. I'm just interested if people agree with me. We can have that discussion over coffee. Any questions for Rob about his work? Because this is really, really important information that we're generating.
Have you thought about... Oh,
Yeah.
Thanks. Have you thought about looking at the peer support that children get at school, and thinking particularly about the first couple of years in secondary school? Because anecdotally, I feel that young people who are unwilling to share their diagnosis of diabetes with their peers do less well. School becomes a conflict area. They're less likely to take a device out and access their glucose or bolus for food. And some of those also become children who tend then not to eat at school. And that creates a big problem.
Hard to pick out in the data we've got, but in the focus groups we did, that was definitely an issue. And it felt like, not to simplify too much, but those who were going to high-performing middle-class schools where they could tell the teacher and tell their peers, and their peers would keep an eye out for them. And there are lots of stories about the peers spotting something. And then other children in more less well-performing schools where they had to keep it a secret. So it's definitely a social, there's a gradient there. And yes, I think that'd be something interesting to think about. One thing that we could look at actually is that some of the children reported that if there was a child who had already gone through the system and the school was better equipped, they'd experienced it once. So I think almost looking for, are you the first child in your school to have type 1 diabetes, or is there a precedent? And that makes perhaps it more acceptable for the teachers, and everyone knows how to support it better. Yeah, thank you.
Can I ask about the data collection? Because I'm sure for all of us, we battle with the child. We've heard the story that if they don't have 100% record of attendance, they're not allowed to go on the school trip or the residential. Yeah. That data was, you said, authorised absence.
Yeah.
Is that for clinics? Or how does the authorised...
Oh, I see. That's just any authorised. So it could be essentially any one. There's a whole load of categories for each of those. But essentially, if you've got a letter from your parents saying had a medical appointment or something, then you're fine. Yeah. And it's more where the parent hasn't justified it to the school and the school's recorded it as unauthorised because it hasn't come through, like you've been on a ski holiday or something, that kind of idea. But I think, I was really surprised at that. At first I thought it was truancy, but I think it's more, it could actually be people where parents aren't getting on with the school and the parents aren't accepting the child's having this time off, and perhaps the school's not understanding that why the child's off. And I think there's...
Yeah. Okay, Justin.
Thank you, Rob. I was just going to ask about the policymakers, how they actually interpreted your data, and did they say thank you very much but go away? And we have Fulia in the audience as well, so I'm going to put a question to her to say, I know this was Wales, but it's likely to show the same effect in England. Do you think that's something that might come into the
Well, I think
transformation programme?
we had to battle a little bit because there were two streams to this. So one where we work with the people who are writing the guidance for the additional learning needs in Wales, where we kind of just had to tell them what to do, and I think they would then just accepted it. But I think that we really struggled on that one because we presented the researchers have done today, and they caught that headline of overall children with type 1 diabetes do as well as their peers. And they're like, oh, great, well, if we don't need to do anything, then that's fine. And of course, it doesn't mean that there's not extra work going on behind the scenes with extra stress for parents, extra stress for children. And so we really had to push it home. So bringing on young people with diabetes into those meetings to talk about their experiences really helped to push that point forward. And then with policymakers, no, we have had a bit of success actually. So we've had to work hard. We've had to get a researcher on not full time, like 20% of their time, just following up on this and keeping that work going. But we have had some success, and I think we've been invited to go on the industrial learning needs like steering group for the new guidance. So I feel like we are making some progress. I don't think it's go away, but then again, you feel like you've got there sometimes with the policy work, don't you? And then nothing, it just dies, nothing happens. And it's very frustrating because I'm a statistician first, and then I'm having to spend all my time getting the data as well on top of that, and then you try and do policy work on top of that. And it's very difficult.
Yeah, you shouldn't have to do the policy work if you're working on the data. The data really needs to be handed over, and policymakers need to utilise it to good effect. So it's not fair you have to do the whole lot. So that needs a little bit of thinking about, doesn't it? Yeah. Anyone else with any questions? Oh, I'm sorry,
Thank you. So Calvin, head of the audits team at the RCPCH. Fascinated by the data. I'm still trying to make sense as we're talking now, sort of wearing through the graphs in my mind. But so two questions. One is, were the reasons for absence from school correlated into this? Apologies if I missed that. And the other would be, I always have this naive notion that when we're talking about policy development here, I don't know how much joined up working between education and health happens. Now, my wife happens to be a very, from what I understand from her colleagues, really dedicated Senko at a primary school. And she'll say one of the hardest things in trying to support the children with different healthcare needs, amongst other things, is the interaction and flow of information between health and education. And then I hear the opposite when I'm obviously in my college meetings, and then it all sort of blows up a bit in the car when we're driving along. But am I really naive in this notion where I think surely there should be a seamless flow of information around a child's healthcare needs from the hospital services to a dedicated named person with responsibility within schools?
I'm sorry to say, the integrated care, and I'll just say one thing, and I'll hand over to Fulia from her policy perspective. The integrated care boards in England have really been set up with integration in mind, and my work at my ICB is very much trying to get education, social care and health working together, and the third sector. And I would say that it's getting better in some areas, and definitely where I work, so I'm a postcode lottery really, but that's what it was all about. But traditionally, before that for us, it was health and it was education, and actually it was very, very difficult for one to influence the other. And we tried hard in health to influence education, but they weren't particularly receptive. But things may be changing. What do you think, Fulia?
Yeah, thanks, Finn. I completely agree with you, and I think we have got new opportunity here going forwards. And as I was listening to you, I just messaged one of my colleagues in the policy team to say, right, this is something for us to look at, because it's fantastic work that you've done and it's really interesting data. And I guess there's different levels at which we influence as well, isn't there? Because I think often it's challenging on a one-to-one patient basis, isn't it? Where, you might find that one side isn't quite as receptive or as helpful as the other. But I think our role is very much to, lead from the top and try and get this right across the board for all the children and young people that we're looking after. I did have a question as well, and my question was, what would you like us to know from a health policy point of view with the work that you've done? What message would you like to give to me and
I
Fiona
think
and the team?
The first one for clinicians would be, I think it's kind of good news that the children are going to, for parents as well, good news that children probably going to attain as well as they might, because you might think, oh no, they're going to struggle in school because they've got this health condition. So it might be a good news story at diagnosis that maybe they're going to achieve as well. I think there's a kind of question for me about, is it the biological versus the social mechanisms through which diabetes might affect your education. And I think the story here is perhaps it is more social than biological, and so it can be modified. It's not something that we can't fix, and I think there's a challenge there to try and improve things for children. I think those two. And
I think the slides that really grabbed me is thinking about those children and young people with the higher HbA1cs and what's going on for them. I think we've got a real opportunity to do something there to impact positively in terms of their health, but also from an educational point of view as well.
I think one of the things we can't say with the data, but is suggested possibly, is this kind of double whammy story that you're probably already struggling with your education, and then you get the type 1 diabetes and you give up, and then perhaps at the other end, you are going to get A's in your GCSEs, you get type 1 diabetes, and you're going to get A's anyway. And so it's almost like this differential effect. So we can't unpick that because of the sample size, but I think that is suggested by some of the things we've seen in the data.
And as the other way we've tackled it locally is to actually not just think about diabetes. We're going in as an integrated care board for long-term conditions, and Calvin leads up the audit programme, but epilepsy, one of the key conditions that can compromise educational attainment, and we're trying to help there. Respiratory, or for the need nebulizers, etc. We're trying to help there. So it is integration for long-term conditions might be a better way forward than just integration from a single condition. And that's certainly how
we try to support the epilepsy audits to get their data, and Dougal Hargreaves we've worked with to get that, but I think it does take a lot of work.
It is a huge amount of work, but very valuable work, because we haven't had that data with which to work with policy. And if you're generating that and with English data, then we've absolutely got more evidence to go and use it. It's a great work. Thank you so much. I'm going to stop now because I think it's coffee time. Is that right? Yeah. Thank you so much. So just a few